Thank you, Shumi. Thanks, George, for organizing such a nice conference with very interesting program. And I was particularly struck by the morning speakers. And David's account was so moving and so powerful. I'm going to talk about neuropsychiatric problems. And I think Alex has talked about general trauma services and rehabilitation services. But many of the neuropsychiatric problems can arise later on, years or sometimes decades after injury. We'll talk about what kind of problems they are, and then we'll see generally neuropsychiatric provision in UK and look at where we go from there. I don't need to touch upon many of these things, but there has been significant improvements in early care for people with acquired brain injuries, and as a consequence, a lot more people are luckily surviving. They are surviving with long-term sequelae, and that remains a challenging aspect. One of the studies from Finland looks at that and reports up to 2/3 of people after traumatic brain injuries or acquired brain injuries. Well, this was just traumatic brain injuries. Can have various neuropsychiatric problems, and we'll look into that. And that's the gap. This is slightly old US data, but the top line reflects people presenting to emergency departments, and bottom blue line represents people who are dying. So that there is luckily a big gap. Lots of people survive, but that's where many neuropsychiatric problems can occur. And arguably, with what Alex was describing, with acute traumatic brain injury services and post-acute rehabilitation services, one can argue that we provide excellent service for people with various physical problems, various learning and cognitive problems, but sometimes emotional and behavioral problems can be overlooked. And this is taken from Headway's page for patients and carers, and these are the range of emotional and behavioral problems that we would come across, and they can be quite difficult. And some of them David was talking about: agitation, irritability, and then depression, anxiety. But this is not where it all ends, and we'll look into some of that. I'll start with very old data, and this is complaints from family, relatives, 12 months after brain injury, and approximately 2/3 of people there are reporting a number of problems, and these are familiar to many of us who work in this area. But the list grows. This is 5 years down the line. Half to 3/4 of people have a much longer list of problems. And I think David's account was also talking about how things evolved and how problems became more apparent as time goes, or there can be other factors like George was talking about. There could be secondary effects, loss of role, loss of employment, relationship difficulties, which could lead on to further problems. This is one of the early studies looking into a DSM-4 diagnosis a year after traumatic brain injuries. And here you would find that the common problems are lots of people having depression and anxiety disorders of whole range, phobic disorders, PTSD. There can be OCD-like symptoms, generalized anxiety, but there can be other issues, alcohol and drugs, and psychotic disorders. This is a study by Professor Dabe looking into so-called minor head injuries a year after traumatic brain injuries. I work in clinical settings, I work in medical legal settings, and I see lots of colleagues reporting, it's only a minor injury and the person should be recovered in 3 months or, a year down the line, surely you're not going to have any problems. But this study indicates that 1/4 of people were moderately disabled, and a significant minority of those individuals still had severe disability after so-called minor traumatic brain injury a year later. This is again from Professor Dabe's work when he was in Cardiff, looking at people who are hospitalized after traumatic brain injuries and using ICD-10 diagnostic categories. And he found again, a year later, lots of people had problems with depression and anxiety, and some people had psychotic illnesses or problems with alcohol. And part of the problem is if we use diagnostic criteria such as ICD-10, DSM-4, often problems are under-identified because many of these problems do not fall neatly into a psychiatric diagnostic category. And hence, Professor Dave's further work on British Journal of Psychiatry more than 10 years ago, when he looked at symptomatic approach, then the rates of problems are much higher. Approximately 40% of people a year after traumatic brain injury were presenting with a whole range of neuropsychiatric symptoms. And this is the Finnish study, Kaponen 30-year follow-up of 60 patients with traumatic brain injuries. And interestingly, what they found was the lifetime risk of neuropsychiatric problems was approximately 2/3 of patients, and that was much higher than the control population. And the current problem rate at cross-section was about 40%. And what was also interesting in this study is that a number of neuropsychiatric problems, including psychosis, can arise more than 10 years after traumatic brain injury. And by then, most of the people are out of any brain injury pathways. They've been discharged from post-acute rehabilitation, community rehabilitation teams, and when they develop these neuropsychiatric problems, often they are referred to community mental health teams who may not be equipped to deal with these problems. This is Professor Dave's work again, looking into elderly population versus younger population, and what he found was that elderly people with brain injury, they're more likely to have more neurocognitive problems, and younger people are more likely to have more emotional problems, but behavioral problems were roughly the same in both the groups. So what is neuropsychiatric service provision? These are common problems. Where do we stand at the moment? So we did, as a part of Royal College, special interest group in neuropsychiatry about 7 years ago. 7 years ago, we started the work, and we tried to map where the neuropsychiatric services are at the moment. And what we found that there were over 70 consultants who said that they were providing some kind of neuropsychiatric input in the UK, and out of those, only 30 were employed as a neuropsychiatrist. That made 21 full-time equivalent neuropsychiatrists. And as we would expect, many of these were regional services based at teaching hospitals. And some of them, a significant minority, were actually working at a brain injury rehabilitation unit. When we looked at what they did, brain injury was one of the common areas, and one of the common areas where they were working. So they were seeing lots of people with brain injuries, apart from a number of other neuropsychiatric areas, particularly epilepsy or movement disorders. When we looked at all the people, apart from neuropsychiatrists, so only less than half of those who were providing neuropsychiatry were actually employed as neuropsychiatrists. There were a whole range of other psychiatric specialists who were providing some sort of occasional special interest clinics here and there in various areas of the country. This is work carried out by Dr. Simon Fleminger from SLAM. He looked at all the referrals coming over a 3-year period, covering SLAM and St. George's neuropsychiatry services. And what he found was the rate of referral to specialist neuropsychiatry services was about 30 per 100,000 population. But as you move away from specialist areas, those rates fall. But more interestingly and more relevant to this audience here, what he found that GPs generally made referral to CMHTs with these problems, but CMHTs said they were not equipped to deal with these problems. They often passed on referrals. Either they made a brief assessment, or sometimes they didn't even feel able to make an assessment and passed on those referrals to specialist neuropsychiatry services if they could. And they gave reasons as saying the skills lay outside scope of CMHT, or these people required specialist assessment or treatment, or they were too complex for them. And this is what Dr. Fleminger's work showed, that what he said was, as he moved away from a center of neuropsychiatric service provision, the rates of referral were very low, and this is where the unmet need was, because the expected rate of referrals was somewhere around that level. There was a further audit in North London carried out jointly by Professor Ron as head of the neuropsychiatry services at National Hospital Queen Square, and with the commissioning specialist services commissioning board. And I won't go into details of, this is a massive document with lots and lots of data, but interestingly, when they looked at satisfaction with the CMHTs, with people with brain injuries, acquired brain injuries, and neuropsychiatric problems, what they found was, over half of GPs and a third of neurologists were completely not satisfied with neuropsychiatric services provided by CMHTs, and understandably so. And CMHTs themselves, in Dr. Fleminger's work, felt that skills lay outside their skill base. And lots of people didn't use those services at all. And this is based on their large areas. So they not only covered London, but Hertfordshire, Essex, and Bedfordshire. And essentially, it shows exactly the same thing. Over 2/3 of people were either not making referrals to CMHTs, or they were largely unsatisfied. And interestingly, here they looked at where, in some areas, some local general psychiatrists were providing a special interest clinic for people with neuropsychiatric problems after acquired brain injuries and range of other problems. What they found was still the level of satisfaction was quite low. They also identified a number of barriers, and they've gone into huge analysis why people couldn't get into a specialist neuropsychiatric services. And one of the biggest barrier was not either availability of these neuropsychiatric services locally or within the region, or lack of awareness. And the second big barrier was, in those days particularly, perhaps it might change now with the national commissioning, there was a significant barrier to referral was seeking funding, and it took a while for clinicians often to seek funding for referral to neuropsychiatric services. We repeated at Royal College our survey briefly about level of neuropsychiatric provision in 2011, 5 years down the line, and what we found that there was 90% increase in number of neuropsychiatric consultants in 5 years. But this 41 full-time equivalent is still 1/3 of what we would expect from what Royal College recommendations suggest. There are a number of training places in the country. There are a huge number of trainees who are doing special interest sessions. So there is quite a lot of excitement and quite a lot of interest, but still the services are largely inadequate. There were total 19 centres in NHS at the moment, and there were 5 centres identified in private sector. And I think there's rapid expansion of specialist inpatient, particularly inpatient neuropsychiatry service for acquired brain injury in independent sector at the moment. So what do various national recommendations say about neuropsychiatry input for acquired brain injury? There have been a number of documents over the years, but in my view, many of them have been a bit hesitant in their approach and haven't gone far enough. The very first of this document actually was led by Dr. Ken Barrett from Stoke-on-Trent in 1996, and it covered not only acquired brain injury, but Huntington's and early onset dementia. And what they said was there was lack of experience in primary care level, but also what they suggested where neuropsychiatry posts were, they were better orientated services, and lack of expert neuropsychiatric input often led on to inaccurate diagnosis of behavioral problems. Subsequently, this matter was raised in Parliamentary Health Select Committee, and Lord Hunt suggested that people with traumatic brain injuries and mental problems should see a neuropsychiatrist rather than a generalist. But even 15 years down the line, majority of patients with traumatic brain injuries or acquired brain injuries would first be referred to a CMHT, and often they start refusing these referrals. Rehabilitation following acquired brain injury, National Clinical Guidelines, ABSRM, they suggested that there should be a named psychiatrist in every health district who should be responsible for assessing and treating people with acquired brain injury with significant neuropsychiatric problems. And specialist psychiatric support should be available to the local community mental health team if they are involved in the care. Alex talked about National Service Framework for Long-Term Conditions, but there was quite a lot of excitement about that. It did talk about meeting psychological, social, and behavioral needs of these patients, but these are the needs still which are commonly overlooked and are often, there is very patchy provision for these needs. Alex talked about, and this is the headway fact sheet for management of acquired brain injury, guide for GPs, and it does talk about neuropsychologists and neuropsychiatrists being involved, and quite often, it's very interestingly, and in your slide as well, Alex, they are lumped together, but they don't exist together in most of the places in the country. They are completely separate pathways to access neuropsychology or neuropsychiatry, and quite often these documents talk about them together, and I think that's where sometimes the problems may lie. There's lots of excitement in literature generally about neuropsychiatry and developing neuropsychiatry services, and a lot being written about. There's an article from Hugh Rickards and his group from Birmingham on that. But still, services remain inadequate. This is the work that was done by the special interest group in service development at Royal College. It was called Special Interest Group in Neuropsychiatry. Now it's called Section of Neuropsychiatry at Royal College. And it came up with guidance for development of neuropsychiatry services in the UK. And generally it talks about that there should be a neuropsychiatry service for 500,000 to 1 million population. And it talks about 3 different levels of services: outpatient services for assessment and management of outpatient services, but also inpatient and specialized clinics. And it suggests a composition of the MDT for neuropsychiatry services and level of consultant input. And clearly, at the moment, from what I had projected earlier to you, we are roughly at 1/3 level of what is expected in terms of adequate neuropsychiatric input in the country. So from my point of view, I think we have this is again kind of hope for the future. But generally, I think there should be a development of a regional neuropsychiatry services for approximately 500,000 to 1 million population, and they could work in hub and spoke model, linking up with local rehabilitation units, community neurorehabilitation teams, and community mental health teams. There has to be strong integration and links with regional neurosciences centers. That happens in a number of places in the country, but in some places it still doesn't happen adequately. There has to be strong link up with most of major trauma centers and post-acute rehabilitation centers. And it's still the case that most of brain injury rehabilitation centers would not have direct access to neuropsychiatrists, or neuropsychiatrists won't be part of the MDT in most of these places. And I think that has to change. They should be core part of MDT, really. And post-acute, long-term post-brain injury patients with neuropsychiatric problems from following acquired brain injury should be seen by a neuropsychiatrist rather than being referred to community mental health teams, because community mental health teams think that skills lay outside their area, and referrers, including GPs and specialists, including neurologists, they are not satisfied with that. So these are common problems, and there are diverse and disabling consequences, neuropsychiatric consequences of brain injuries, some of which could start many years after brain injury, by which time people are often not within any brain injury pathways. And still, the neuropsychiatric services are very patchy and inadequate, and they are not properly integrated and linked up. And like Alex said, the holy grail would be to have a pathway where people can get into neuropsychiatric services when need be pretty quickly, without any of those barriers we talked about. Happy to take any questions. Thanks very much.